This is Susie Penman on July 29th at about 11:15 in San Francisco, conducting an interview for the Global Oral History of PEPFAR project. And I'm joined here by my colleague, Jonathan Mangula. And Dr. Goosby, to begin, could you start off by introducing yourself, telling us a little bit about who you are, what you do?
Sure. I'm Eric Goosby. I'm a professor of medicine at UC San Francisco School of Medicine, Department of Medicine, Division of HIV and uh, Global Health, and I'm also in the Institute uh, uh, for the ISG is an Institute for Global Health Sciences is kind of where you are now. But the UC, as most departments, medicine, and that you're interviewing people in, you're in a department in a university, and you're also maybe in an institute. You can be in both at the same time, but your appointment comes from the department, so it's always a little convoluted. But I've been at UCSF really since medical school and my residency fellowship, and stayed for faculty as the HIV outbreak began in the early 80s, and became the director of the clinic in the Bayview Hunters Point was an extension clinic of San Francisco General, and it was called Southeast Health Center. Still there. It's the building is run and owned by the city and county of San Francisco. It's a 330 federally funded community health center, and but it has been there since the late 60s, and run by the city and county of San Francisco in terms of the bricks and mortar. But the nurses and doctors have always been UCSF faculty, and this particular health center has been an extension of the Department of Medicine in that role. So I was the first kind of UCSF medical director for Southeast Health Center, and it was in the Bayview Hunters Point, which is in the south part of the city, and in a predominantly African American community, and it's been that way since World War II. And HIV bubbled up in that community as I was there. Now, I was internal medicine and infectious disease fellowship, and was always keenly interested in infectious diseases, knowing that Southeast Health Center was in an area with a high prevalence of sexually transmitted diseases, but also of TB and Hansen's disease, which is leprosy. I had a special interest to kind of be there, and started that clinic. But all of my patients began to come in with late stage HIV. San Francisco in 1981 was seeing people who'd really been infected for about a decade prior to that, and had been symptom free. As you know, the incubation period for HIV is a decade. People get infected and are largely without symptoms after the initial infection. 2 weeks later, they're symptom free for a decade. And in that period, they infect others. And that's why HIV was so efficient at embedding itself in populations and spreading, even unknown to both the patient and those that they were infecting. So it's a tricky bug. And because of that, really has effectively taken over large chunks of the planet. At the time, it was just beginning its drumbeat, had been in sub-Saharan Africa for years prior to 1981, but we did not recognize it as a disease really until 1984. 1981, there was no test for HIV. We didn't know how it was spread. If you remember the COVID kerfluffle we just went through, you go through a period of looking at how the virus moves both through an individual as it infects them, see what part of their immune system it attacks first and how it does it, what cells are engaged, what cells are lost, which give you most of the signs and symptoms of HIV. And I would say that the our ability to diagnosed really wasn't enhanced until 1984. We didn't have a blood test for HIV from 81 until 84. In 84, doing the research at San Francisco General, we developed a blood test that was able to identify the ratio between your CD4 helper and suppressor cell count, a certain type of white cell that the HIV virus attacks preferentially and kills it. So you eliminate your CD4 cells, which you need to identify and clear fungal infections and cancer cells. And when you don't, you get the opportunistic infections that HIV manifested with at the time. So in 1981, we were called to the emergency room to see infections we'd never seen before in humans, except in people who were on chemotherapy and had wiped out their bone marrow. These types of opportunistic infections were what we saw with HIV in the first years. And really, it was out of that that the blood test was developed, and it wasn't until 1986 that it was commercially available. So for a long time, we looked at this disease move through individuals in front of us, and 100% of them died, and look at it move through a population as it hit the community and move through it. So understanding that movement and quantifying it, developing surveillance strategies that documented it, was all part of that early work. And it all occurred at Southeast Health Center and the 5 other clinics in the city. So the typical scenario was we meet the patient and we know at that point that they have a disease that will kill them. And because of that, we got very aggressive and good at identifying early and treating it, diagnosing and treating the opportunistic infections. And San
Mhm.
Francisco distinguished itself for being a place, if you had HIV, where we could keep you alive longer than other places because we aggressively treated opportunistic infections. In some instances, gave prophylaxis, developed the whole strategy to give you drugs that treat the disease when you get it before you actually manifest with actual symptoms of the disease. So in your repeated exposure, you don't contract the disease. For the AIDS pneumonia, pneumocystis, it worked. For TB, it worked. For some bacterial infections, for hepatitis infections, which are very high prevalent in HIV infected individuals. They suffer terribly from recurrent sinus and eye infections, ear infections, and it dominates the early part of an HIV infected person who's not treated with antiretrovirals. So that was the clinical picture. The numbers were so great, we decided we needed to have an AIDS dedicated inpatient unit, and we developed that at San Francisco General called 5A. And we also developed an AIDS dedicated outpatient clinic for the first time in the country, and that was Ward 86. I was the associate director of Ward 86 with Paul Vorberdien as the director. Paul was really did more in the research arena solely, did not do, really didn't follow a cohort of patients. And there were kind of the clinicians in the AIDS clinic, then there were researchers, and then we merged those two together. And it's one of the first times in medicine where you had a meeting of both clinicians and researchers in an aggressive kind of convening to identify what the organism was, what the natural history of the HIV infection looked like, and where in the immune system it attacked the individual who was infected, what opportunistic infections came out of that, how to treat it came later, but we were actively looking for anything that had an antiretroviral component to it. So something that worked against the virus. I did a lot of work with Japanese mushrooms, shiitake mushrooms. We did watermelon, Japanese watermelon, because it had antiviral effect in a petri dish. And eventually pulled a drug off the shelf, AZT, which
Mhm.
was a drug that had been developed for chemotherapy for lymphomas, but had never been used for that. And we noted that it did have antiviral effect at the AIDS virus. In the early years of HIV, we couldn't do a test for the virus, as I just told you. We had to culture it. which takes about 10 days to 2 weeks to grow it in a medium that allows it to grow, and then the presence of it is the diagnosis of it. Crude, but it's how you start when you got a new bug to develop diagnostic tests. Then you start looking for antibodies against it and things that are surrogate markers of the infection. And that just takes a longer time. But all to say that the AIDS clinic was something that was a response to desperation, to increasing crescendoing numbers, and to the growing fear in the community, especially the gay community, that there was this disease that selectively took them out, and that there was no diagnosis for it or cure for it, and that this was the plague that everyone had feared and thought was that they initially thought HIV was. That fear stayed for about 5 or 6 years, where we weren't sure how it was going to move through the population, and we were primed for what occurred. If aerosol spread, we would have had a very different outbreak, and we saw that with COVID. That was a virus that was spread through the air, and thank goodness HIV wasn't, but it changes how you approach it, and I think we've just gone through a COVID rollout that kind of shows you how an aerosolized spread virus should be responded to. At any rate, that resulted in a series of meetings convened by President Reagan. He appointed a advisory committee that was headed by an admiral from the Navy, and he went around with a director, with a kind of a dean from the School of Public Health in Minnesota. I've forgotten her name now. But they went around and went to about 7 epicenter cities that were disproportionately impacted by HIV in the United States, and convened a meeting that met with the AIDS treaters in the city, met with the city leadership politically, and met with the impacted community, which was included large sections of the gay community, and then just poor community membership was largely in minority communities right from the very beginning. The first cases reported were in African Americans and injection drug users and in gay men. And those were all in the first reports of HIV in that summer, all included those 3 groups as targeted. And sure enough, those were the groups that remained targeted throughout the epidemic in both the United States and Canada and Europe. As I'd said, the outbreak had occurred for decades before in sub-Saharan Africa and had killed hundreds of thousands of people at that time, but a surveillance system was not in place to tell us how many people were infected in the world or in a heavily impacted country. We just knew from looking at their delivery systems that their hospitals were full census-wise with HIV, their emergency rooms were full, and there were 2 to 4 people in every bed in their hospital. That was what was going on in sub-Saharan Africa in kind of the mid 80s to late 80s, but began to crescendo in the early 90s, where those numbers just got untenable, and the world became aware of the disproportionate number of infections in sub-Saharan Africa, basically in countries that had no access to diagnostics or therapeutics. And they get infected, and 100% of them succumb to the infection. On the planet, the people with HIV in developed countries died from opportunistic infections that were protozoan infections that were mostly coming in through the lung and through the GI tract. But in sub-Saharan Africa, Southeast Asia, China, it was all TB that killed HIV-infected people, still is today. So the leading killer in developed settings were a different kind of constellation of opportunistic infections than they were in sub-Saharan Africa. In sub-Saharan Africa, or places where there was no ability to treat people or to diagnose them, they all would succumb to TB, and that was how the TB rates in the 90s, late 80s, just skyrocketed, and they were all from HIV-infected people. TB now, as you know, is the leading infectious disease killer on the planet. So TB has supplanted an HIV lead and is now killing more people than any other bug you can name out there. So the meetings of the advisory committee set up by Reagan went for 3 years. I was asked, as were people in AIDS dedicated efforts in Los Angeles and New York City, to inform the processes of this kind of roaming advisory committee, and that went on for about 3 years. They basically took testimony from everybody and did nothing with it. So it went to nowhere, but it was compiled a similar thing that you guys are doing. And at some point, somebody looked at all of it and said, maybe we should set up an AIDS advisory committee that lasts and runs. And that was proposed to Reagan, who did not do it, um, but the subsequent government's engagement was forthcoming, and they set up an advisory committee in HRSA, Health Resource Service Administration, which is where the culmination of these this group that would go out and meet with uh, advisory committee that would meet. Their recommendations, which you can still read, were that they should set up a funding line or make Medicare available for indigent AIDS patients, because the progression for HIV was you'd start out employed with a job, with insurance, you'd get ill, you'd use up kind of your sick time and have to go on disability. So we called it the medicalization of HIV. Everybody with HIV ended up on disability in those years because of the presence of opportunistic infections and their inability to work and their eventual death. So it was just this move from not being on a funding line paid for by the government to everybody being on a funding line paid for by the government. So we made the argument. Yeah, sorry.
Sorry, I'm sorry to interrupt, but I just want to get your perspective on something you're talking about. As a doctor in one of these epicenter cities who's seeing, like 100% of people die from this, what were your hopes when it came to what federal intervention looked like? What did you hope could be done by the advisory committee or any of the resultant groups that was formed? As a doctor, what did you really want to see happen from the government?
Yeah, the entire drumbeat that came out of these convenings of these advisory boards, these committees, was that the federal government needed to take HIV as a different disease and make available federal resources to diagnose and treat it, such as it was at the time, which was shitty. Okay, you might as well our ability to do something for a patient really was preventing the opportunistic infections from coming, putting them on prophylaxis to prevent those OIs from being the thing that killed them. But over the course of 2 to 3 years, something else would kill them. So that you prophylax for the diseases you could prophylax for, but you couldn't get all of them. And toxo or cryptococcal meningitis would eventually take them out, or TB in the United States would get them eventually. So they all died 100%, and that we weren't used to taking care of diseases that had 100% deaths, except in the arena of cancer, and that was a different. With infectious diseases, you have the expectation that you're going to cure them at the outset. You don't at the outset move to a palliative strategy, whereas with oncology, for many of our cancer patients, you are doing that at the beginning because their advance of the disease is enough that you don't have chemotherapy that can pull them back. With we looked at HIV in a similar way at the time, but my expectation was that the government see HIV as something that results in total disability for a patient, and that the government, like they do for other things that disable patients, should pick that up as something they pay for. So that was
Mhm.
my whole argument and the argument of the committee and the drumbeat that I was on. That was the only side that was being articulated. It resulted in a discussion that resulted in the Ryan White Care Act. And
Yeah.
the Ryan White Care Act is a PEPFAR for domestic epicenter cities that was passed in 1991. I was asked to be the first medical director of that and left UCSF and set up took the legislation, which was just language about we need to do something, came out of those convenings. And the thing that they needed to do was to develop a new program that got the name Ryan White because there was a teenager who had gotten it through a blood transfusion, HIV, and had been ostracized and rejected by his class and school to the point where it had become publicly known, picked up by local newspapers. So we decided that to have a gay male as the face of HIV would be politically harder to do than if we had a young heterosexual kid as the face of HIV. So being very transparent with him, but mainly his mother, went through that whole discussion. Uh, 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 was the person who convened that a lot and helped us with that. He was the legislative lead for foreign, the, I guess Senator Kennedy was over the foreign appropriations committee for foreign ops. And Michael was the lawyer that was their legal advisor for that and worked in Kennedy's office for most of his career. Ryan White was passed in 91. I went back to DC and decided what the legislation was going to buy. It was $20 million or so initially to go to epicenter cities, greater than 2,000 cases reported. You were eligible to ask for money from the federal government. It would go to the city that was burdened and to the chief elected official, and it would set up a planning body that had to decide what the unmet need was in the city for HIV and what was met, what was unmet, and prioritize the unmet need. So which one's more important than another, and then make allocation decisions to fund that from the Ryan White Award that the city would receive. And it was not for surveillance or research per se. It was for diagnosis and treatment program money that could be linked to research, which is what we do, and created out of that the AIDS clinical trials group that NIH ran. These things all came together eventually, but they started as separate efforts. But the Ryan White Care Act went to up to 52 epicenter cities over the course of its life. It's still running to this day. How it worked with Medicaid and disabled people was something they set up working groups for when I was in Ryan White to figure out, should we just make everybody disabled and everybody goes on disability, or are we going to keep that special program for the AIDS infected individuals as they come into more and more service needs? And it was decided after a couple of 3 years of back and forth that there was real utility to keeping the kind of special populations that come into being infected by HIV, specifically gay men and injection drug users, are ignored by your medical delivery system otherwise, and that this was an opportunity to create a conduit of access and retention that came in through an HIV expectation and diagnosis that carried the person through the duration. When we developed effective antiretrovirals in 1994, took a decade later after we developed the test. The antiretrovirals that we used from the early 80s to the mid 90s would prolong your life for 18 months, and that was it. So we'd start you on 2 to 3 drugs, and we'd extend your life for 2 to 3 years, and then you'd die from an opportunistic infection that we couldn't treat. Then in 1993, the first highly effective antiretrovirals were discovered and made available. And we rapidly, through the Ryan White conduit, took them to those epicenter cities first. And the funding for drug and diagnostics and monitoring labs came through the Ryan White conduit and not through a Medicaid, Medicare disability conduit. And that decision was what enabled Ryan White to remain as a separate program that was worthy of separate funding as we kind of continued responding to HIV and it growing. So in 19 let's see, I guess it was 90, um, early 90s, maybe 92, 93, in a meeting in Amsterdam, an international AIDS meeting, challenged the community, and Peter Piot was the voice of the challenge, that it was unacceptable, unethical to continue to not respond to the burden of disease in sub-Saharan Africa. 78% of the people infected with HIV were not getting access to anything and were dying. And they were all in 12 countries in sub-Saharan Africa. So that drumbeat got President Bush's interest in a disparity of response that was not justified, and as a I would say as a ethically defined motivator, President Bush saw the unmet need in that untreated group as unacceptable, and out of the blue decided he was going to incorporate this into his allocation portfolios as we got up to the State of the Union address and his announcement that these monies and resources were going to be made available. He had solicited my input at 4 or 5 times before that decision was finalized. I, with Tony Fauci and Mark Dybul and Paul Farmer, had been brought to the White House on 3 separate occasions to kind of give testimony to, can you go to a resource poor setting? And I had done it, and I had set up clinics in Rwanda and South Africa at that point that were run by nurses. And I went in thinking that wasn't going to work out. I was skeptical that a nurse could successfully, safely, reliably diagnose and treat HIV. Now we don't even think about it. But at the time, it was blasphemy to think that a nurse could actually do a sophisticated treatment regimen that required juggling of labs, decisions on new drugs, starting, stopping, blah, blah, blah. And now nurses mainly do it on the planet, but in those years it was like, okay, should we do this? And I think in a very real way, HIV led the way for kind of that mid-level providers expansion into therapeutic and diagnostics. Really came out of an HIV support, not a support of TB, which did the same type of thing in every country. HIV did it 20 years later. The same diagnostic and therapeutic challenges for TB remain that are there for HIV. They did it with TB on a kind of 30% level of the unmet need. They responded to about 30% of the need in these countries. Not fully, not a full response, but it was the same thing as HIV was needed. And, you know, the first pandemic unresponded to was TB. Then the second one was HIV. But, you know, we did not respond like we did with COVID on a global or country level, but we should have. And so anyway, I've kind of lost track of what we were talking.
No, you're anticipating like 90% of my questions here, which is great. But I do want to pause and ask you a little bit about, because you've moved on to talk about Africa now, and I want to know, it was through the CDC's Global AIDS program that you said you first traveled to Africa in any meaningful way. I think it was Zambia that you were referencing. Can you paint the picture for us what you saw? I mean, you've been so immersed in domestic HIV and AIDS treatment. What did you see?
Good point. Yeah, I would have been characterized as the domestic HIV person, not international, had no international focus, intellectually understood where the epidemic was, but it did nothing in my practice or research to address it because there was no funding for it. It wasn't that I didn't see that as the preferred need or an equal need, but there was absolutely not a drop in the bucket to respond to it. And the IAS meeting in Amsterdam that started the drumbeat with Peter's talk challenging the AIDS community globally in this is ethically indefensible, and that we as a global community need to call foul on ourselves and say that that is no longer something we can just look at, where we are going to have these a growing disparity between those who are diagnosed and treated and those who are not, as a function of where you lived. And that in those times was enough to get guilt going strongly enough to want a response to come out of it. And I think, you know, President Bush's administration was responding to 9/11, and in that response passed, you know, a law that basically opened up a U.S. response that would not have to be approved by this, you know, legislature if we go to war with somebody. Iraq happened on the charge of weapons of mass destruction that, as you know, were never found. But at the time, we did not know that until years into it that they wouldn't be found. So I think that President Bush, feeling that he was in need of a balancing portfolio in his administration's work, I think was looking for a meaningful, not pretend intervention that had global consequences. And HIV was sitting there. And he was smart enough and moved enough, I think emotionally, to see the morbidity that that disease represented as something that he could do something about, and listen to people who told him that was true. And I would say Tony, Mark Dybel, and myself were the loudest voices giving the data, but it was all Rwanda and South Africa's data that they based the calculations on. Could we do this? So from, you know, probably 8 clinics worth of data, the decision to do a 15 countries and $15 billion type of response opened up out of that. And I have to give that, I have to attribute that to President Bush's vision to see and respond to a huge unmet need that he didn't have to. And nobody, quite frankly, else was telling him to do it. I was in and around all those voices, and the main response was, "You must be kidding." I mean, that was really the main response. He did this in spite of the opposition, and how people recommended you know, he not engage on this. It was felt that it was a mistake, but to his credit, he saw the need, responded to it, and didn't look back. So,
were you surprised when PEPFAR was passed? You know, and I know that you were involved in some of the preliminary talks about it, but when it actually, you know, that moment at the State of the Union when he announces it and it begins to roll out, what was your feeling about it?
Well, I had known from talking to Tony that he was going to make an announcement. So, and I figured this was going to be something along these lines. Didn't have any of the specifics, but knew that there was an announcement that was going to be made. But at that point, Tony was at a central point in guiding kind of how they should put it together. And Mark came in about halfway through that uh, uh, to kind of take it into the first implementation challenges as the first. You know, there's a person named Joseph O'Neill who was also the medical director of PEPFAR that you probably haven't spoken to, right?
No,
Why not?
no.
Is there
No
a reason?
reason.
I'm just curious. Yeah, yeah.
Oh, no, there's no reason other than we would love to.
Yeah, no, Joseph O'Neill, and the first director of PEPFAR. I'm just blanking on his name, but I sure hope you've spoken to him. He came out of motor vehicle. He was the director of Chrysler
Randall
Motors.
Tobias.
Tobias, yeah. He's a guy who was in private sector making cars. And so this
Yeah.
was a real change of his routine. And he really got into it. And I have to say, a lot of his early thinking as a business person really changed what we were able to do for the better with program, 5 years later, that kind of thing, which is a whole nother story. But I'd encourage you to talk to Tobias. He's a sweet energy, and I think it'll be productive for you. And he's certainly part of the story. All
Yeah.
that early discussion was him. It
Mhm.
was him with mostly him and the people he convened in the PEPFAR in the early PEPFAR office. That was Joe O'Neill, and then later Mark Dybel. Later in the way of like a couple of months later, they were there
Yeah.
together. Yeah. But anyway, so I would say that the sub-Saharan African response was breathtaking to see, and without the United States seeding of it, there would have been none. When we got there, we were building a new program. The first 5 years or the first 4 years of PEPFAR were really developing MOUs and relationships, and there wasn't a lot of program to ground at that point, and understandably so. And it was really the second 5 years that you saw rapid acceleration of number of people identified, tested, entered on drugs, continued on antiretrovirals, and the lives saved numbers really started to grow.
Mhm. And when you were involved in those early meetings with Fauci and you mentioned Paul Farmer too, um, what were some of the other concerns of that group, in PEPFAR's potential rollout? I know, you mentioned the idea that, could this be done in resource poor countries? What did that conversation look like? How did you get around it? What were your thoughts on it?
Well, I guess I would say my thoughts were informed by, having had a decade in Ryan White, or 5 or 6. Well, how many years was it? It was 90, is 80. I guess it was 91 to 94. So I was only in there for 3 or 4 years. But in setting up medical delivery systems 52 separate times in that time period, with new people, new convenings of planning councils, working groups, having to set up MOUs and memorandums of understanding and agreement with mayors of cities, with governors, and with people in DHHS and Center for Disease Control, NIH, and HRSA. It became the blueprint for how we thought about PEPFAR, quite frankly, because we'd done it in a very concrete way 52 times in Ryan White. So,
Mhm.
so those understanding who needs the importance of defining an unmet need and prioritizing that unmet need and making the allocation decision done by a separate group, not the planning council because of the conflict of interest, but to pass that once the prioritized unmet needs were made to another entity like the mayor to make an allocation decision, or the board of supervisors, or whomever you would identify, but another group so the conflict could be managed was, I think, the biggest lesson that we brought to PEPFAR that came out of Ryan White that I think really made our program immediately better. Eliminating that conflict, because what you do is you convene everybody who diagnoses and treats HIV in in a capital city in a country. Those are the people you're also going to fund. So they're going to say they're needy and that their needs are important, and now funder fund me. Now that was the dynamic that you were setting up everywhere, and you had to manage that, or you were going to have a core of corruption that would just grow. And I saw that in PEPFAR over the years too, that it always did grow. But you've got to aggressively recognize it and manage it when you see it.
Mhm.
Let's see. Um, I would say that that the role of the United States in this convening was critical because there was no other country or entity that played the role. It was what this work has taught me, you guys, is that to think that a foundation like the Bill and Melinda Gates Foundation could have enough resources to respond to a global need is what a lot of the early foundation, the creation of a lot of the big foundations that had an interest in global health. The first response was that they're our savior and they can do everything. And what this work has taught me is that they never had the potential to be the savior. It was a mistake to think they could play that role. And we decelerated our activity by holding that expectation up to them. It was always a government charge and a government problem because it was their people who were dying and they were charged to respond to the health and needs of that population. And what was missing was the ability to hold that political system accountable to the lack of response for the population that they looked at dying for 20 years. And and getting that the dots connected in countries holding their own political system and leadership accountable for not responding is where we are right now. When I came into Ryan White, I mean to PEPFAR, that disparity was huge. The first attempt at PEPFAR did not address any country expectation of country government ownership. Whose problem is this? Who's charged to respond to the death of their population? The government was, and the government was not responding, and the population wasn't voting in a new politician as a result of that non-response. It was a broken system, completely broken, no accountability, and our ability to encourage and force countries into funding it once the United States was going to come in and fund was not successful. Indeed, every country we came in with, we funded. So PEPFAR funding for any ministry you want to name was 2 to 3 times the whole budget for the Ministry of Health for every other disease and problem they got. Everywhere we went, everywhere we were. Okay, so I'd come in with $500 million to South Africa. Their budget was 180 million. Their whole budget for their department, just to give you a feel for what you're this elephant in the room with more resources than they could dream about for one disease, and you're coming in and not wanting to displace kind of the prioritization systems that the government has in place. Instead, PEPFAR should have joined in that effort and used the PEPFAR resource to facilitate the completion of their vision of what's needed for their population, but to completely embrace the HIV unmet need, but to allow them resources to do both. A nurse could take a blood pressure for hypertension, diabetes, coronary artery disease. That same nurse should be used for that. We don't need to buy a nurse for each separate thing, but that's what funding from a funder like a foundation or a country going into another country, giving money for a project or a problem, that's what it ends up doing. So you create parallel systems of care, and PEPFAR had the potential to be a huge mistake. And when I came in, I tried to swing that pendulum back from, so the early PEPFAR, you guys came in and created parallel systems of care. It didn't come in and use the clinics of South Africa or the hospitals. It came in, found new storefronts, emptied them out, and built a new clinic, and built 5 new clinics, and then put 5 other clinics in another town that was kind of nearby, and maybe had one hospital that they often created that would, as from a private sector perspective, now take patients as they were in need of inpatient care from those 10 clinics that you built with your PEPFAR resources. Parallel system, not part of the Ministry of Health in South Africa, not their clinics, not their personnel, not their medical delivery systems, not their procurement distribution system, not their pharmacy formulary, all of which was hugely disruptive. To go into a delivery system and use different drugs than the system is using to treat a disease that they're treating is disruptive. It creates a different standard that you don't have to create. Anyway, more than you want to hear. But all of that was not done. And the start of PEPFAR was blind to all of those needs. And I would say the Ryan White experience for me made me very aware of how those needs are barriers to you completing your continuum of care as you stand it up. And so I tried to put the expectation with governments that this is a partnership, you're a partner government, and that we are co-responding to this infection. We're going to build off of the system you've already built, not create a parallel one, and your system will be stronger for it when we're through. And so for about 3 years, we moved it in that direction. A lot happened in that time period. We went from 1.7 up to about 6 or 7 million people with a drop in funding for PEPFAR with less money. And we still were able to expand from, and then eventually got up to 12 million with the same pocketbook. And then subsequent additional monies came in that allowed them to get up to the 27 million, which they're doing now. But, yeah, so.
I want to talk a little bit about the moment when you came in 2009. PEPFAR had been around for several years at that point, and I want to ask about how you approached the job. Mark Dybul's departure, I think, was both celebrated and condemned, and here you are coming in to fill this role. Can you talk about how you approach the job and the sort of contentious and highly partisan aspects of it? Because you are, as you say, you're trying to make these big changes to the sort of behemoth that is PEPFAR, all of this money, all of these ideas about what it should look like. How did you handle that when you came on board?
I tried to put it back in the country's, I tried to shift responsibility to the country back to, or to start the definition of what the unmet need was and the process that defined and prioritized or, prioritized which unmet need was more important than another, that be done by the country and not by a committee in Washington, D.C. And so the way PEPFAR was run when I came in was a committee would meet in Washington, D.C., take a budget that was developed in part a little bit by the country people who were implementing the program, but had really measured input into it. It was really done by the PEPFAR American people who were working in the country for PEPFAR, paid by PEPFAR, Americans. That really was how they defined their where and what the allocation next year was going to be. It wasn't a in-country defined understanding of unmet need. And I made it that, okay? I shifted it to the country's needs to define what their met and unmet need is. And we need to, in agreement with them, not doing something we don't want to do or don't feel we should do, find areas of commonality and where we're happy about joint funding. And those were easy to find because the unmet needs are so large. So it was really just being smart with the largest pot of money in the room and not hoarding it and creating a parallel system of care, which was really dumb in terms of the strategic mistake that reflects. It was telling the country everything wrong, that they weren't strong enough, capable enough, good enough to be the system that we wanted to put our system on. And therefore, we're just going to turn our back on you and create another system of care that has nothing to do with your system. And also a procurement distribution system, which you don't realize is the core of a program, is how well you can stand up a procurement distribution system to bring the diagnostic reagents and drugs into the clinic or the hospital every day, all day, 365 days a year, so your ability to diagnose and treat something is preserved. And when that gets interrupted, everything stops. So making that country ownership the primary objective was the big change.
Did you have any conversations with Mark Dybul when you first came on about,
Yeah, you're referring to you're referring to the way Mark was removed? Is that what
Uh,
you're referring to?
Partly,
'Cause, I mean,
but also,
that was like an afternoon of angst that really bothered the uh, Mark and everybody that was part of PEPFAR initially was very confronted because it happened uh, inappropriately with a phone call by a subordinate. So it'd be like if there was someone sitting in this conversation and they went out and phoned up Mark Dybel and said, you need to pack your bags up and get out of the office, turn your cell phone in, get your phone, because we decided we were going to go to country ownership. So the discussion in the meeting was we need to do country ownership. And somebody in the meeting that was really at a subordinate level just left the room and phoned Mark and said, get out of your office. That's what happened. It's more than you wanted to know about it. But I know it really upset Mark. But he phoned me up that day, phoned Hillary up. We had nothing to do with it. It absolutely was something that happened by in the White House by the chief of staff in a throwaway statement. And if we're going to take PEPFAR, we need to make PEPFAR more responsive to country priorities, and that translated to the person listening to it is we needed to get rid of the leadership of PEPFAR. There was no question that they were going to change the directorship of it, but the way they did it was excuse me, disrespectful to Mark and the system and completely unnecessary. But I got to tell you, that's what happened. It was kind of a mistake.
mhm.
But that's the
um,
worst of it. Nothing bad happened from it.
yeah. I want to know, this is a really basic question, but in layman's terms, can you tell us the role of the U.S. Global AIDS Coordinator? You know what, like day to day, when you come in to work, what are you doing? Because PEPFAR is huge and there's so many people involved, and I'm curious to hear like sort of the definition of that role in particular.
Yeah, I think each of us did it differently. For me, I divided the world up into regions and kind of the um, the degree of the HIV response, completion versus not completion, and viewed each country that way, and worked on the specific elements of what I call the completion of their continuum of care and services. That's what we built, continuum of care and services. And that included the ability to diagnose HIV, once identified, bring them into care, stage them for opportunistic infections, find them if they've got them, treat them if they've got them, cure them from the OIs, and then start their antiretroviral. And that, those three things were needed to save their life. And we got very good and efficient at it and monitoring and following that particular patient to know when we lost them to follow. So I have strong capability and so the prevention from mother to child transmission, which had not been started in the early PEPFAR at all. So I initiated activity that would eliminate pediatric HIV, all of which was achievable in every country we were in because the numbers were still small in it. And we made huge strides toward elimination in 11 countries in my time in PEPFAR that that eventually years later, by 3 or 5 years later, resulted in them having almost no cases of pediatric HIV like it is in the United States and Europe.
Mhm.
So that is something that happened that we didn't really herald or feature as an accomplishment. I should have. There's some articles written about it, but I mean in terms of talking about the program that way. PEPFAR now talks about the program as a huge uh, intervention in ending pediatric AIDS.
Yeah, I'm glad you mentioned, you know, the features that you would decide to herald, as you put it. I mean, I'm jumping around here because this is kind of one of the concluding questions, but because we're talking about it now, a lot of Americans still don't know about PEPFAR and about the role that it's played, you know, and the impact that it's made globally. Do you think that heralding certain features of it is part of that? You know, why do you think it is that Americans don't know about PEPFAR to the degree that they maybe should?
I mean, the only reason to talk about it is to continue funding the same need, because the
Yeah.
need is still there, and we have not successfully turned the corner on HIV globally to the point where it's over. And so all of those needs are there. Uh, PEPFAR is a extraordinary example of an effective intervention that worked. Didn't complete it to the end of the struggle, but is as an example of effort put toward problem that got major movement on the problem. There's no question that PEPFAR is the only example I can think of its kind. And not only is it the largest public health response on the planet ever, but its effectiveness and its ability to say it was effective is higher than any program I've ever worked with. The surveillance and accountability, the self reflective monitoring that's done in all of the systems of monitoring that PEPFAR stood up is why it continued to get funded for 25 years. We were able to tell appropriators in Congress something they were not getting from any other program they funded. What happened with the money? How many people did it serve? How many people were diagnosed? How many people were treated? How many lives were turned around? All of those things I can tell you for PEPFAR. There's not another disease you can name where they can tell you what those numbers are, including in the United States for the killers in our culture for hypertension, diabetes, and coronary artery disease. We don't do that we don't do that kind of surveillance. You'd have to talk to Kaiser, Sutter, and every United Healthcare, ask them what their numbers are, total it up, and then reflect it, because we don't have any surveillance system for our own work. We are like a developing country in how we deliver and monitor the effectiveness of our healthcare delivery system. We basically don't. And we don't because those who make money from it want to preserve their ability to do whatever they feel they need to expand their profit margin without regulation intervention. And they see anything that the government does as increasing regulation, which is complete bullshit, but that is what you hear from everybody. What regulation is created, I defy you to tell me. And even now, when we talk about the current administration, regulation is the first reform they get out of their mouth. There, there, there was no overuse of regulation that you can name me in the work I've done for my whole career. What are you talking about? And it's an area that should have had regulation but didn't, because the preservation of a profit margin capability is still what this country prioritizes and preserves. And I think PEPFAR is a great example of it, and the programs in and around PEPFAR. Uh, the the utility of this program for goodwill and soft power messaging of America is involved in saving people in your country who are dying from this disease with no expectation of we want something from you, but because it's the right thing to do and a contribution to the greater good, got a whole lot of yardage out of it. And that soft power narrative is gone now, and I would say is going to bite us in the end in a big way. It's going to be the thing that hurts us most. But I know that there's a administration now that just thinks it's absolutely not necessary. I've just seen it be the critical convening reason so many times in diplomatic discourse that to eliminate it is going to change the role we play from here on forward. PEPFAR was used as a convener in so many non-health related discussions, I can't tell you. And the diplomatic facility that good gesture of a 25-year investment in your country by the United States and your people and the lives saved is hard to argue that you don't care. And that put us at the table to discussions that we had nothing to do with, but they wanted the United States at the table because we were the country that did that with them in the last 20 years. And they want that awareness in the discussions they're asking for a new relationship with the new country. So all of those conversations are not happening in this administration, and it's tragic. But, you know, so there you go. So I don't know how that came out, but it did. So.
No, I appreciate it. I appreciate the candor too. I want to go back to you being the U.S. Global AIDS Coordinator and talking. I want to ask you about sometimes competing, definitely varying interests of people who have their own ideas of what PEPFAR should prioritize. So I'm talking about treatment and prevention, treatment versus prevention. You know, those kinds of conversations. How did you, as director, manage that pressure, those competing interests, and what were your own ideas about it?
So, you know, I had been in an AIDS dedicated practice for most of my professional career, from getting really out of my fellowship, and really that gives me a long vision understanding of how a disease interacts or doesn't with a medical delivery system over time, and how well the individuals in that delivery system do for getting their disease removed, you know, treated and eliminated. I would say that the so you were asking me about what? I've kind of lost
About how you balanced different ideas concerning treatment and prevention, and also,
So,
yeah, yeah.
yeah, sorry. That tension is real. It's the medical industrial complex that PEPFAR built them in two areas. One in multinational NGOs or domestic NGOs that developed an expertise in the prevention portfolio focused on HIV as the disease, and the same for diagnostic and treatment skills for NGOs that, you know, came out of that whole AIDS era. That, just like a military industrial complex, these are entities that need to get a budget every year, and that's their raison d'etre, and they fight for it and buy lobby time for it in large amounts. And it's become one of the biggest lobby efforts on the planet in the United States, challenging the military industrial complex in its K Street presence. So the ability to keep that cash flow going has become the prime directive, and that's mainly the energy behind the prevention effort. In 1993, a study was completed that we stood up and put in PEPFAR and completed in PEPFAR that showed definitively that treatment with antiretrovirals drops your load down below 1,200, but as soon as it gets below 20,000, you don't see that person infecting other people. In fact, we saw it first in PMTCT. Women who had a viral load below 20,000 didn't transmit to their babies. That was the first clue we saw. Then we did the studies to do it. We completed the study in 93, and it showed definitively that antiretroviral treatment is the best prevention intervention known to the science. It prevents transmission 98, 99, 100% of the time. If they're undetectable, 100% of the time. The 90 to the 2% that didn't show protection were people who had who were not completely undetectable, but were moving down as they started their antiretroviral. They were going to undetectable, but hadn't achieved it yet. Once achieved, they don't transmit. That fact went into the prevention treatment community, and the prevention community tried to ignore it for years, saying that that's just not true, and that you need to fund separate prevention efforts, not think of a treatment intervention as the definitive prevention, but the science says that it is. I'm not saying we shouldn't do prevention efforts. We should continue many targeted prevention interventions that target high-risk groups. All of that needs to continue and increase. But what we don't need to do is act like once we start them on treatment, that those prevention interventions are still needed the same in that individual. If they move to undetectable, you do not need to waste your system's prevention effort finding, targeting, and retaining people in front of you as a delivery system once they're undetectable on their antiretroviral drugs. And your delivery system can stand down and use the resources else, and no one argues with that if they know the science. So the only people you'll hear that other side from, I think, have a conflicted motivation, and it's a survival motivation that they're really responding to. Mm-hmm. So I think that the treatment prevention fight is artificial. It's not really a fight, and that we need to do both, but that the prevention interventions should mainly be targeted and focused on identifying, entering, and retaining people in care over time, the duration of their life. So, the long-acting antiretrovirals are coming in now. We now can give you a shot that lasts 6 months. The implications for prevention for that, and if you're a person out there having high-risk behavior, I now don't need to convince you to take your pill every day to prevent you from being a transmitter. I now can give you a shot that I give you twice a year that guarantees you're not going to be a transmitter. So the prevention effort is about to get a lot better. Mm-hmm. Right now, we could do 2-month injections, but we just got FDA approved a 6-month injection.
I want to talk more about the emphasis that you placed on in-country partnership and ownership of PEPFAR efforts. And I want to get to some more specifics about what that looked like or could look like to you as far as various country government agency and participation in PEPFAR programs. Can you just tell us a little bit about, what that might have looked like, more specifics? Because, talking about government agency and ownership of a program it's a huge goal. Like how did that sort of trickle down and what did it look like on the ground?
Yeah, I guess I would say it's much more straightforward than people think. It's using their clinics and hospitals instead of building our own PEPFAR clinic and our own PEPFAR hospital. Use theirs. Infuse your resource into their system so their capability expands, and measure it. Know that it happened. Don't guess at it. But by using their clinics and hospitals, you preclude that need for a harmonization. You're harmonizing at the beginning. Once you start a planning process that's inclusive of that continuum of care and services that you've stood up. So the way we map out PEPFAR is, I know for you too, I want to know that there's a place where you can get tested, that once tested, if you're positive, you can quickly be in front of someone who will diagnose and treat your opportunistic infections and then retain you in care for the duration of your life. Not small expectations, but that's the system we're entering and the continuum of care that we're funding. And I, at each point, know you're in care, retained in care, or you're lost to care. So I can get my system fine. And that's where the whole healthcare provider idea came out. And Paul Farmer was early on thinking about this. Healthcare workers as accompagnators to a person is not a practical solution to your patient needs to go to their appointments and follow up with lab work and blah, blah, blah. To have somebody telling them in their ear to do all of that is a luxury that most systems can't afford. So the healthcare workers solution, and this is where Paul and I disagreed with each other, is a short-term solution, not a long-term solution. And most countries don't have the money to pay for a healthcare worker. You need to put as a new position, you need to kind of piggyback on an existing position in their delivery system. So we did healthcare workers. South Africa doesn't have a civil service position called healthcare worker. So we created this thing that this South African civil service couldn't fund when we leave. So it's doing that kind of stupid stuff is what they did. So easily avoided if we were in a common planning process, not rocket science. We just didn't talk to each other. We would plan in Washington, D.C. and come and implement it in Kigali, but the conversation with Kigali in Washington was through paper and emails and reports, and not a planning body that was in front of the population that used and depended on these services. So that disconnect, instead of to think that Washington or Geneva could know what the unmet needs are accurately, be responsive to a need in country, that the population that was timely and connected to a response that the patient recognized as related to their need being met because they said something and the system responded. Kind of connecting those dots is what makes your system believed in by the people who use it, and it gets stronger on its own. So there's a lot of those types of things that I think happened in PEPFAR over time that we're losing now with this interruption. This simple little quick interruption, everybody in PEPFAR looks for another job immediately because that's the model that they're used to. A funder goes away, they don't come back. They go away and we all scramble to get another. So that's what happened when the USAID programs were decelerated, 3 months ago, with no explanation or process before, during, or after. We're going to lose most of the people we're losing are people we're not going to be able to talk to again to bring back. They found other jobs and they've moved on, is my point.
Yeah. And now, overseeing PEPFAR would have included tremendous collaboration with USAID, with HHS. Can you talk about some of the dynamics between USAID and PEPFAR during your years as director?
Yeah. The thing that took up most of my time was interfacing and harmonizing between really USAID and CDC. The two big implementing countries agencies were USAID and CDC. CDC had a larger portfolio of treatment sites in clinics that used antiretrovirals, but they both did it, and they both did it well. CDC was connected to more of the medical type model brain they hired in their parallel systems of care, because both CDC, but especially USAID, created parallel systems of care. USAID, I don't think, used one clinic or hospital that was of the countries until was all, storefronts that they go in, meet, greet, and develop a new relationship with, set up a clinic, remodel a space, and away we go. And that was the model that early PEPFAR was. All unnecessary, all redundant, all creating a parallel system that we knew we wouldn't want to continue forever. Inevitably would need to be integrated back into the main system. Or what are you thinking? So I would say that that my main energy was, I mean, knockdown fights between the USAID staff and the CDC staff around who was going to control a budget, a clinic, a problem solved or not solved, who was going to take the lead on it. Both fought for it and fought viciously, and it was the most difficult thing as a physician I've ever had to deal with. And I've only managed physicians with each. My career has been managing physicians doing their work. Professors of medicine, but people who have egos and think that they're the cat's pajamas are who I've mainly corralled into doing work. And it's a different art form because of that, because these people have spent 20 or 25 years getting educated and think that they can't be told anything and have real expertise. So you got to work all of that through to kind of get the best out of people, but it's not hard to do. And and people who some of the best people in CDC and USA, people with medical director exposure in their past lives manage this best. But the fighting that would come out between the two agencies was manifest by a belief system in USAID that generalists were their preferred person. They didn't like a person with a degree, with a higher degree, just in general. You wouldn't see a higher degreed person, an MD or a PhD, be the director of anything in USAID. They would have their person be the director and hire the MD, PhDs to work underneath them. The the success in USAID was the larger the budget, the more credit you got in their system. If you so they would the first thing out of their mouth when they would talk to each other was how large a budget have you managed, and that was their feather of accomplishment, and it does reflect that they've managed a larger budget, and that's harder to do than a smaller budget without a doubt. So it's not like it doesn't tell you something. But in USAID, it wasn't what research you've done, what medical delivery system did you stand up, what new drugs or vaccines have you discovered or implemented, any of that. The feather in the hat was my budget was I had a $70 million budget that I managed, and let alone $1 billion budget or a $7 billion budget, but those are better. So that told the USAID management administration if they should promote that person or not. So people got promoted by the size of budgets they'd had an exposure to. CDC would get a promotion by articles you've published and in what journals, much more like an academic institution. It's just their culture. And as to why that's the case, it has to do with who was in CDC in the last 20 years, et cetera, et cetera. But it created a angst that dominated my time. So the fights I had to deploy myself to resolve, because I was the only one that they would accept the decision on, was the fighting between those two agencies. The utility of the global AIDS coordinator having complete budgetary control is the reason it worked that way. The Bush administration understood the importance of putting that person in the position of budgetary control and reporting, a presidential appointee, an ambassador with Senate approval, gave you all of the bells and whistles to be the definitive word. So when you went into a country, you were an ambassador at large, which in the diplomatic hierarchy is the highest ambassador next to an undersecretary of health in the State Department, an undersecretary position. You were at the kind of the same level as an assistant secretary, and that gave you in the bureaucracy an ability to get it done. But the budgetary control legislatively defined in PEPFAR legislation is the reason that occurred. And in creating PEPFAR, that was very much in their mind to make sure that that person had the ambassador title, had a diplomatic cachet, and controlled the budget. And that's the only reason I could mediate between the agency fights. If that budgetary control wasn't there, they wouldn't have listened to me. They wouldn't have come to the meeting.
So you touched upon something I wanted to ask about, which is how global AIDS sits within the Department of State. And can you talk a little bit about working with Secretaries Kerry and Clinton while you were in that role, and sort of how it was situated? And
yeah, so you report directly to the secretary, and that is a advantage. But you also report to the president. So, like, I had a monthly meeting with the president throughout the entire time, and it's a formal meeting with an agenda, and you go over things that he's interested in or I'm interested in, and the big decisions were brought to that meeting. But Secretary Clinton completely managed PEPFAR as something that was a high priority to her. It was within her inner box of levers that she felt she had in the role as secretary as a soft power tool, her biggest soft power tool. And she used it that way very actively. We started an initiative that brought ownership back to the country, the country ownership initiative, which we did a tremendous amount of writing about within PEPFAR, paperwork wise, justifying it. But we shifted the entire priority of what we did as PEPFAR's programmatic reflection. It was how many country partnerships did we complete? And we had set out to do a country partnership agreement, a diplomatic agreement with every country, which would have shifted ownership and budgetary control in part to country in that gesture, not completely, but it would have begun the swing to do what now everybody wants PEPFAR to be, run and managed by the country that it's in. So we saw that then. It was Hillary's vision that it was embraced. That ability to work with her and her ability to support me in working with Obama, arguing that something needed to happen, was seamless. And the reason that we were able to move those resources so freely and increase, from the 1.7 to the 7, 8, 9, 10, 11, 12 million people with a drop in funding was because of her willingness to trust and move quickly with those country ownership agreements, the country partnerships. And we were only able to do, and Kerry loved them and embraced them, and we continued to do them with him, but it decelerated under his tenure because the countries we were doing them in by the time he was Secretary of State were much harder and had been less worked on by PEPFAR over the years before. So they're harder countries to stand things up in. So not a surprise what you'd expect. So the number of partnerships, the interest in, I would say that Secretary Kerry's priority of climate change moved some of the importance that the bandwidth I filled as PEPFAR with the Secretary of State off. His climate change interest was huge, appropriately, definitely justified. We were happy he was doing it. But, I spent most of my time taking Hillary with, when she would go to a country, there would always be a PEPFAR agenda. And with Secretary Kerry, even non-PEPFAR countries, Hillary, this was an important enough issue. She wanted, and it was a kind of a catch-all word for soft power agenda. What's the soft power agenda in this country I'm about to visit? Even if I didn't go with her, I'd give her a take on what the potential PEPFAR health related issues are in that country. And she'd go into discussion with prime ministers and presidents that included, from her perspective, her bringing up this, soft power issue. Always got great positive reactions from the host country because they were not expecting her to bring something like that up. But Hillary's genuine interest in soft power is well known and was well known before our time together. And I think that's what reflected that. I think Kerry's interest in climate, he would have prioritized and said he prioritized HIV in the same way, and I would, support that he did. It's just that the countries got harder as we moved in to his tenure.
Can you talk more about that? The country's getting harder. You were saying that's because the infrastructure wasn't there already? These are new countries.
Yeah, so our relationship with the first wave of countries that were identified as PEPFAR countries, started in 2002, 2003. And from that moment on, PEPFAR had a large budget. The smallest budget we put in was $200 million. The largest budget was 536. But the countries got a huge chunk of money that dwarfed their Ministry of Health budgets. And biggest elephant in the room it's going to displace and domino things in a way for everybody that needed to be managed. And I would say that that the countries that we were in from 2002 until 2008 had, 5, 6 years of attention that the countries that came in later didn't have. And that makes a huge difference in what you can stand up in them. So they needed that preliminary work, infrastructure work, but relationship work, which was the slower part of it, establishing relationships with individuals in ministries of health, then at the local provincial level, because PEPFAR went from 2 clinics in the capital to 250 clinics in the country. Okay, we're talking about at scale stand ups. And that process of going from a couple of little clinics in the capital city, easiest city in the country to work in, to rural, remote, not easy to work with, having to set up procurement distribution systems, often for the first time with some of these sites, was kind of the challenge. The other thing that I think Hillary brought in that was very smart and advantageous is she insisted on a civil society meeting every time we went into a country that convened civil society proactively with the Secretary of State meeting with a PEPFAR context. And that was used over and over again. The situation in Uganda with the legislature passing a law that made sodomy a crime punishable by death, made it a capital crime, was managed by me and the U.S. ambassador to Uganda, who was there at the time as an ambassador to Uganda, were able to engage with Museveni around our dissatisfaction with this. And we were able to be credible in saying we weren't happy with this because we'd had 20 years of investing in his population, and his people had saved hundreds of thousands of Ugandan lives that would have died, and he knew it. And that gave this interaction a context that wouldn't have been there for a country that didn't have that history with him. But having that history with him, we were able to get him to take that legislation and table it, pulled it off the agenda item for 3 years during my whole tenure, and it didn't get back on until 2 years after I left. Okay, they put it back on, and they've gone back and forth with it again. But it was because of that credibility and trust that happens because of individual relationships that we took advantage of the moment. And I would say the importance of civil society and convening them every time. She was probably in Uganda 5 times over the course of her 4 years. And in each convening, civil society saw that that was important and attended to, and part of the PEPFAR response, but was the reason we had credibility with the president of the country. But that's an example of it. And with Carrie, we did very formal partnerships too, but we got smarter at it, and we'd convene 4 countries to sign the partnership and not have to bring him to each country. We brought them to the United States to have a little ceremony to do it, which the countries love, and it was a different way to do it. So,
I want to ask about the Global Fund, because OGAC also led U.S. engagement with the Global Fund and other multilaterals too. But can you explain again for an audience who's not familiar with how PEPFAR and the Global Fund work together? How they work together or alongside each other.
Yeah. So the short version of that is the PEPFAR budget included the allocation for the Global Fund award every year. So it was my budget that had to have the Global Fund award in it, and that was billions of dollars in addition to PEPFAR was $4 billion, went up to $7 billion with the Global Fund every year. And that had to be argued for in Appropriations Committee and defended in Appropriations Committee by me or the Secretary. But they usually, PEPFAR is the largest program in the federal government. I don't know if you knew that. It's next to military allocations. There's nothing that even comes close. It's much bigger than uh, so what that size does is it gives you status in budget discussions in OMB, Office of Management and Budget, and you become the person in appropriations presentations that presents the program part of it because you know the program in detail, and the secretary doesn't feel comfortable presenting that to the appropriators. So all the appropriations committees, the global AIDS coordinator presented the budget. You see that still, it's still the case. But I forgot what you asked me. So.
Well, you're partly answering about how PEPFAR and the Global Fund work together or alongside each other.
So was responsible for them, but we worked in the House and Senate to in appropriations committee to increase or maintain the funding where it was. And Mark, when he left PEPFAR, went to the Global Fund as the director of the Global Fund, and in that role played the convening role for both Global Fund and PEPFAR's contribution to it. So continued to be in the dialogue for that with both hats on. But I would say the necessity of PEPFAR having to have a third of the money come out of the United States fixed the total pot high enough that other contributing countries had to contribute more. So the U.S. putting a third in increased the gradient that there's more money needed in the pot, and each time has held that because of that requirement, which is in the legislation. And that is kind of how PEPFAR has played a funny role in the Global Fund discussion. Many countries, especially the European countries, look at the Global Fund as their sole contribution to global health now. So all of them after 2008, after that global recession, all the European countries, all of whom had contributed a bilateral program like PEPFAR to the Global Fund, to the precursor to the Global Fund, and decided to continue that. And I guess I would say that the main the ability to move that number up or down has kind of been diluted with what's called the Friends of the Global Fund, which is a multinational NGO in the United States, Japan, Austria, Norway. They and in France, and they, as a multinational NGO, lobby their legislatures for more money to be donated to the Global Fund in each of those home countries. And that is coordinated by the Friends of the Global Fund in Washington, run by a guy named Chris Collins, Collins, who's definitely someone you should talk to. He's like a Michael Iskowitz, has been kind of the outside civil society leadership that has kept the drumbeat loud, and he's one of the more effective ones. So he's effective and credible for the whole duration of Ryan White and the Global Fund and PEPFAR. So he goes through all of them as a effective activist. He worked with me when I was in the HIV/AIDS office in Clinton's White House. I was the associate director of national AIDS policy with Sandy as a director. And I was the medical director and kind of the policy person. And he worked with us in that office at the time. So he goes way back to those early days. And right now, I'd say he's kind of the most successful at keeping the Global Fund funded at the level it is.
Mm-hmm. We've been talking a lot about money and budgets. And you just mentioned the 2008 recession. And with all of this in mind, I want to ask, what sort of funding challenges, other funding challenges did you face when you were Global AIDS Coordinator? I know that when
They
you,
decreased. Sorry.
sorry?
I was going to say they decreased my budget by 12% my first year. And that was not something that they had anticipated doing. So that was, I didn't expect to, to be asked to come in to do a program that they were going to drop. But they dropped it every year I was there by a little bit. But this year was the biggest. And then they kind of trickled money out after that. Funding was always a fight, and always how it was divided between the agencies was the second fight in that fight. So how much CDC, USAID, NIH, FDA got, because PEPFAR used all the public health agencies depending on the locus of the expertise, and didn't reproduce or recreate staff to recreate that capability. We used capability that was already present in government. My time in Ryan White had taught me where those places were, and my research time with NIH, I knew a lot of what was out there in those agencies. So if I didn't have that knowledge, it would have been different. But I would say because of that, we were able to keep PEPFAR at 99 people, most of whom were in countries. We had, 3 to 4 people in each country, in all the big countries, who were paid by PEPFAR central office. But PEPFAR is a program that really did all of that work with 99 people, but then using agencies for everything else. And that was where the lion's share of human resources and our costs were. But we would get CDC to do treatment programs in these countries, and developed a curriculum and a training curriculum that would be implemented, created by CDC, but implemented in USAID programs that they were over as well. So the products were shared across all of PEPFAR, and worked well that way. But I would say that that the CDC fight around which agency controlled which country was something that I started out as the biggest fight we had, and then over the course of 4 or 5 years, we're able to push it down to where those decisions were not up for grabs every year. So they would have a new fight every year in the way PEPFAR was set up, and which would just wear you out as a managing a program. But I divided it up into problem areas that crossed countries and where the problem was implemented. So we didn't have a homologous recreation of every issue in PEPFAR in every country. I cross-countryed a problem for so a procurement distribution problem that couldn't get a reagent reliably to a laboratory, and as a fix for every laboratory. And we didn't just fix it one place at a time. We really applied it broadly when we identified those solutions. And that saved a huge amount of money. The USAID's approach, if I could just say it, would be to, if they were in the USAID office in India, would set up a new McKinsey-driven analysis of a procurement distribution problem that we'd already solved in Mozambique. And PEPFAR Central was aware of all that after I started to manage them. We were aware of what one country was doing and working on, and shared the solutions with all countries. That became a very efficient thing as time went on. We got better and better at that.
Yeah, it sounds like you had to be pretty nimble on your feet to handle constant budget reductions and issues around financing.
Yeah, we were always in 3 budgets. I know, it was really a trip. I was always working in 3 budgets. The budget that we were currently in right now, the budget that we were finishing up that was ending and the budget that we were planning to finalize for next year. And so I always had three budgets that were swirling around. But as time went on, you got better at it, quite frankly, and it got more efficient. But the biggest rate limiter was the lack of country ownership of these programs and the need to have to talk to Columbia to get a fix in a clinic that was, in up in northern Ethiopia. Uh, and that kind of craziness went on for a long time. So the people who were managing the clinic in Ethiopia were paid by a grant that came from PEPFAR, went to Columbia, and then out to Elizabeth Glazer Pediatric AIDS Foundation. And they ran the clinic and were the interface with the actual day-to-day management with the central office part of the equation. And it just diluted the system so much that there's a point at which that becomes inefficient. And I tried to take us through that period and move us back toward more country ownership. But I'll tell you, the people who fought that gradient of moving back toward more country ownership were the people who were most invested in the system remaining unchanged. And it usually had, um, what I would call self-serving reasons for them to want to not change it. It's because it preserved a resource for them that they didn't want to have go away. And they wouldn't be upfront with you about their concern about the resource. So you have this crazy conversation over and over again about what it wasn't about, trying to make a decision to start it or not, or stop it. Anyway, more than you wanted to know about, but it did dominate all of my time for years.
No, this is,
You know,
I can assure you, none of this is more than I want to know. This is all really interesting. So thank you.
yeah.
Can you tell us a little bit about the Scientific Advisory Board and the role that it played?
Yeah, so the Scientific Advisory Board is used to bring in advances or standard of care practices that were accepted and had become standards of care uh, in the in the diagnosis and treatment of HIV and TB. We did both of those diseases, and that advisory board was the platform on which the information about the effectiveness of treatment preventing transmission. That was first brought to the Scientific Advisory Board. It was a New England Journal article uh, 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 that was brought to the group, discussed in the group. Michael Cohen was the guy who was the lead author on it. And he came to the group, presented it to the group, and had been a member of the group earlier on in the Scientific Advisory Group history. So, but it facilitated the incorporation of a major scientific advanced discovery that had major programmatic implications immediately. And we were able to take it from the discovery to the implementation challenges, strategy, needs that very quickly. And we implemented it seamlessly. So the article came out, on day one, and by the third month we were implemented. We'd already made all the changes we were going to make to the system to better ensure the initiation of ARVs early on.
And this is, I think, somewhat related, but OGAC completes an annual study of treatment providers. Can you tell us more about that?
An annual study of treatment providers. Tell me more about what you're referring to.
It is excuse me, an annual study that OGAC would complete. I think assessing treatment providers, if I have that wrong.
Every year, just as part of a routine management requirement, we looked at the data from every site, and we looked at the things you'd think would look at, but it basically was only focused on trying to identify areas that needed to be strengthened or eliminated, but mostly strengthened. And it would be looking at the surveillance data for HIV testing, positive, negative, viral load, what the value itself was, initiation of ARVs, what the value changed to, and did they or did they not reach undetectable. And those were monitored on everybody that we had, which gave us a kind of sequential reflection of their engagement at each point in the clinic system itself. And we had it by site. So we could work with the providers in Clinic A and talk to them about their population for how many they're following, who they are continuing to follow. Are they adherent to their medication, or is there a question as to whether or not they're taking their meds because their viral loads are still elevated? And if they were taking their meds, they'd be undetectable. And that creates a different visit the next time that provider sees them. But our ability to know fully inform the providers so they could act. So we didn't monitor anything we weren't going to act on, is another way to say it.
And now a question about the COPs, the country operating plans. Can you tell us how all of those annual plans, which contain so much data, how they came together in your office?
So, so I had a map of every country by the continuum of care and services that they stood up. So for South Africa, for what's the entry point for them to get tested? So by site and by number, how many sites are there that can do HIV testing? How many were tested? How many positives were found? Of the positives found, how many were started on antiretrovirals? So we know denominator and numerator too. So we know how well we're doing at each step of the continuum of care. The OIs, opportunistic infections that were diagnosed and treated, just to list them, we did that. But what it does to a provider, it gives you a reflection of what the system is doing to that patient, successfully or not successfully, over a period of time that highlights fixes. So it doesn't just do it for the hell of it. It does it and shows you where you're losing them, where or what area they're not adhering to. This person clearly isn't taking their meds. You need a whole new strategy to convince them that this is something that is going to kill them. And you'd think that death would be enough of an incentive, but for most people, it isn't. Most people can hear that and still not take their meds, smart people. So it's kind of a trip how that works. But I don't know if you've ever had to take a medication, but it's harder than you think. And there'd be days you don't even feel guilty about not taking it. You just forget, go on about your day, and everything's good. But in a disease that kills you, those misses are noted, and the virus doesn't miss it and rapidly starts dividing. And it's an exponential division. So 30 to 60 to 120, that's how this thing goes. So in 6 weeks, you're undetectable. I can take you back to symptomatic in a month and a half with HIV, untreated. So it's a cure. They won't infect anybody. They won't progress themselves. They'll truly die from something else if they're on antiretrovirals, but they've got to take their meds. So that's why these long injectables are going to change the game.
And
take
all
that adherence issue out.
Yeah. And all of this data that was gathered in the plans that would, the country operating plans that would report, where PEPFAR was succeeding or not succeeding as much as it could be. How would y'all aggregate that data and use it going forward? Does that question make sense? I'm just curious how all the COPs would come together each year.
So they came together country by country, as I say, for areas within their continuum of care that are steps or needs. We understood each step, each need, and could see who came into that step, who came out of that step and moved to the next step. So the continuum of care was visualized, understood, and documented. And that gave us more control than your primary care in a highfalutin private practice has on most of their patients. It was extraordinary, and I don't reproduce that in any other system I've worked in. The system I'm here in at San Francisco General can do something close to that, but not as good as it was done in the PEPFAR model. But but I wouldn't ask for anything I wasn't going to make a decision off of, and I would argue that everything else should be eliminated. Debbie Burks took the data collection up to an absurd level. She collected things that they'll never look at or need to know. And she's an epidemiologist by her orientation in a lot of the way she thinks. And, uh, and they like more data than less. And that's what I think we got caught in there is just a
Mhm.
lot of data. But she wasted a huge amount of money and resources in doing that. Not as a criticism, just as a what are you thinking? What were you thinking you were gaining by that huge investment? The largest investment was in surveillance data for years after I left, and there was no need for that. If your job was to take those four clinics in the capital and make them 250.
Mhm.
Okay, that's the prime directive, and that was why we got up and did work every day, was to take it to scale, not just to the elite four clinics in the capital effort, which was a lot of the early PEPFAR.
Yeah. And so you wrapped up your time as coordinator just as the reauthorization legislation was introduced to Congress. Is that correct?
Well, every 3 or 4 years it's introduced. So yeah, that's correct.
Can you tell us about the work that went into preparing for that bill?
Um, uh, well, the it mainly the Global Fund has a similar data collection burden that they do. It's not as robust as this PEPFAR one, but it's close and redundant and in more countries. So it's even bigger than the PEPFAR one. I think they're in 53 different countries, which is kind of a trip. But I would say that PEPFAR did most of the work Global Fund takes credit for. And I'm not saying that as a competitive thing, it's just a fact. No one would argue with that. The numbers they report on include PEPFAR numbers, and the PEPFAR numbers are the larger contribution to the total burden of disease treated on the planet for HIV. So we're in their total numbers, in the 27 million that they talk about, 25 of them are from PEPFAR. Our program, when I was there, our program was efficient and effective in a way that Global Fund was still struggling with in most every country. We were able to do it faster. Because of the parallel system of care, we took it out of the country's hands often to stand up the continuum of care. We went in, found the sites, and built it, and that in some ways is easier than working through the country. And for the emergency part of the PEPFAR, they wanted to go quickly, but it was really a at no point should they have thought that this was only going to be an emergency response. But the argument in appropriations was facilitated by calling it an emergency. And as you see, it's been kept for 25 years. But do we have a 25-year emergency? Well, we want you to believe we do. And arguing for more money, it's hard to say the emergency is over. But and that was the problem they created. But anyway, so I guess that's kind of that. Uh, Global Fund is PEPFAR and Global Fund were very competitive in the first 5 years. They would try to outdo each other. When I started, they were both in Malawi, and there was a pharmacy for Global Fund and a pharmacy for PEPFAR, and a lab for Global Fund and a lab for, and I immediately blew that up. That was the dumbest thing I'd ever seen. That had occurred in a number of countries, but we stopped all of that. We either they picked some countries, we picked others, or when we did do the same country and the burden of disease was highest in a number of countries where that was justified, we just didn't overlap. We did, yeah. But so I think that the Global Fund is a answer for many European countries. They're going to
Mhm.
come back to a program portfolio. So they're going to keep, all of them, France, Germany, UK, Italy, are all have not done anything to rekindle an interest in creating or restarting programs that they historically had done for many years. All the ones I named had a bilateral program in a country or two, not many countries, but Germany had stuff that went on in Rwanda and Burundi that people don't even know about that they funded on a bilateral level. All of that stopped when in 2008 when the global fund when the recession hit, and none of the European countries came back afterward. They all stopped. None came back. DFID went away. UK got rid of DFID, which was their state. They're like USAID was DFID,
Mhm.
and they absorbed it and put it in their uh, foreign policy offices and did away with DFID completely. So they, even though a lot of the people they didn't let go, they let a lot go. So UK's capability went away and never really came back.
How did that drop off in uh, global healthcare intervention affect your job at working with PEPFAR? I mean, I imagine it placed more pressure on PEPFAR to get certain things done. Is that correct? Or
Yeah, Global Fund continued during my time at PEPFAR as it has now still. And it didn't recede in a country specific way, but the conversation in every capital in Europe went to, we can't continue to do this. And they started to threaten withdrawal in every country. And then in another year, they they kept when they receded in '08, they all just kept it. Hadn't decided to not restart until a year later. So it was a stuttered start that we thought wasn't going to be a complete stop, but it ended up being a complete stop. And to this day, they haven't restarted. So I would think that the Global Fund is the only conduit through which these countries can do anything internationally on a health level, and they should preserve that at a minimum. And that's been the argument I have brought to individuals who are in countries that just do Global Fund now. But they're getting pressure in every country you can name to not continue the Global Fund. So the discussion in all the too. And they historically had always been fully present, especially for women and children programs, but they've even pulled back. So it's a funny time. It really is. I'm feeling that unless we can get a shift back to the people who need and depend on these services in these countries, holding their politicians accountable for funding this need, we're not going to get a benevolent, resource out there in either a foundation or in another country. What happened with PEPFAR is an aberration and wasn't repeated anywhere else. And I'm really not optimistic that there's a, a desire to do something like that festering out there. I'm not hearing it.
Mhm.
Yeah.
Can you talk a little bit about your transition out of the position of director? What was it like? Did you have the opportunity to share your experiences with your successor at all?
Yeah. I had known Debbie for 20 plus years, and she succeeded me, and we were in talked about anything she wanted to talk about, and we talked a lot in the first couple of months, and then she having been in the field her whole life, didn't need to talk to me about much of anything really. So it was more just to kind of hear what she was thinking and doing. I told her about the surveillance predominance being, I thought, a mistake, but she really felt it was important. But I would say the main thing was having been in PEPFAR in every global health discussion on the planet, to have that suddenly stop. I went through a withdrawal. I did feel that I was out of the loop in a way that worried me because all the discussions were serious, but they were all kind of critical moments. As global health just keeps everything at a critical moment, it never really gets into status quo. And but I would say that was the biggest change. Feeling out of the loop and learning to be comfortable with that was a relearning. Also, walking through airports became, this experience of having to get in lines, having to pick up my luggage. As an ambassador, you're picked up at the door of the airplane. They put you in a little golf cart and take you to the car that takes you away from the airport. You've already found your luggage and put it in the car, and that's really hard to walk away from. The convenience of a airport changes. You're thrown back into just one of the people in line again, and that's always a jolt.
Yeah, welcome back to real life.
Yeah, back to reality.
So we're winding down here. When you reflect back on your time working, well, you worked in the White House for years before you were working directly with PEPFAR, but so when you reflect back to your time working in the White House and more specifically with PEPFAR, what are your thoughts? And I know that's a broad question, but just reflecting back on the work you've done in the government working with PEPFAR.
Yeah, no, I think it was an honor and a privilege to have an opportunity to think at a large scale and to have an impact on so many different lives. Uh, uh, I've uh, I've I've only taken care of patients and only been in life and death diseases with them has been the predominant thing I've been in front of. But the ability to uh, have a privileged position and view of what that part of humanity is going through is something that I've always seen as exceptional and very grateful to have the opportunity to see such uh, serious human dilemmas, one after the other, hundreds of these types of dilemmas, and seeing how human beings have only 5 or 6 different reactions to any problem in front of them. And being in a position to be able to see that is so privileged that I'm forever grateful for it. And know that that became international with the work when I stepped out of a domestic focus into the international focus. And the perspective change is that we're all the same. That's the perspective change. That's the big epiphany. And no kidding with that. We really are all the same. And it's just a tragedy to see the huge differences we put forward as being so important in how we differentiate and separate ourselves from each other. Humans are pathetic in the way they degenerate to this final horrible common pathway to reconcile their difference is, moves quickly um, to an expedient, efficient, uh, no matter what, caring, don't care kind of if there's a win-win doable and available there. I'm not really interested in figuring it out. And that's kind of the world we're inheriting now. The win-wins are falling off the plate and people are less interested in going for that win-win. Whereas I grew up in a reality where the win-win was where we started the discussion. And that's how the politicians in my cohort thought of what they were there to do, truly. And that's out of Hillary in Obama's mouth. That's all they, if you heard them speak about a problem. Same with President Bush. I've been in front of him enough to hear him engage on problems, and he was always looking for a win-win. But this other agenda has crept into our reality now, and I don't know where it's going to end. I can tell you that it's a different fight, and I'm just kind of realizing that now, and not sure exactly how it'll manifest. But I'm convinced we're going to have to engage in a way that was thinking we may not have to before. But I don't think we're going to have the luxury of it just getting better on its own. And this kind of program is not going to ever come back into favor in the world that is currently making decisions. But the people that thought this old way aren't dead and are still in positions of power and authority. So I haven't given completely up, but we need to repair and recover here in a way that allows that greater good to continue to be a destination that we're all working toward. Because to eliminate it and take it off the plate is wrong. It's a big mistake.
And when you think back on your career and your time with PEPFAR, what are you most proud of? And on the flip side, are there any areas where you wish you had done something different, or anything you might have changed?
I guess I am proud of the lives saved, the lives that continued because of the interventions that we built. And my knowledge that they would not have had they not had that opportunity to get in front of the right pill in the right mouth at the right time is a accomplishment that I know is ephemeral, and we almost didn't get it. And at so many points, it could have crumbled. And that reality, really makes me want to pass the baton to the next group of people who, the knowledge is there and the understanding is there to solve most of the medical problems that are in front of us, but definitely improve them by 70, 80%. Most of the people on the planet don't benefit from the science we've known for years, but have not applied to them. And most people don't know that they aren't getting the science we already know applied to them. So that disconnect just is allowed to go on and on and on. And because medicine has become the largest profit generating sector in our economy, people have nodded their head to, we're going to let some people make a lot of money off of this basic human need that every human has, and we're going to let some people benefit by making a profit off of that need by making the patient pay for it. I just think that is so wrong in a society that is so rich, and the implications of a life well lived and potentials achieved and met are dependent on a healthy body and a disciplined mind that is willing to take and engage and take a leap. And that requires a support system that gives them the room to feel they can take that leap. And I think we are strong enough and rich enough to create environments that educate and give them that health foundation so the competition is really equal, and you let them run out of the gate and go for it, but only when there's an equal playing field. Until there's an equal playing field, it's unfair and ethically wrong for a country to pretend like there is an equal playing field. And I feel the United States is acting like it's all just equal out there and everybody has an opportunity. Not in the world I've been in. Where are you coming from to believe that? That is not the world we're in. But if you've created a bubble around you that can convince you that we are in that world, I don't think that's healthy, and I don't think you're going to be a better person for it. You're going to raise strange children who have priorities that are not working toward that greater good. And that narrative needs to increase, not fade out. That needs to be, blasted to the next group of kids coming up, so they're driven by it. And I don't see this administration even sensitive to any of those agendas. And I'm really worried we're going to have a dead period that just comes out of the interval we've created with this deceleration on just every sector and every front. But I'm mostly worried about the medical and international front. We're definitely going to get it hit. But other than that, we're good. So.
You've talked in the past, I listened to an interview with you where you talked about the camaraderie that developed among staff and healthcare professionals working in the San Francisco General AIDS Clinic in the 1980s, how y'all were brought together in large part by, the trauma of it, as well as the working hours and what you were all going through. Have you observed something similar among those working under the broad umbrella of PEPFAR, a sort of collegiality?
At a site level, yes. So when you get down to the clinic or the hospital or the emergency room that feeds the 5 AIDS clinics feed into, you see people, especially who went through the pre-PEPFAR era in their country. Those people have that camaraderie. They get the call to and the challenge that the call to service is reflective of, and have made the sacrifices and commitment to respond to it. That group is still in place often, although they're all in their retirement age, and they're all now leaving the systems that we built PEPFAR in. That provider is still there, but they're the senior person in the clinic, in the hospital. They're retiring now. It's going to be different when they're gone, because that's the cadre that remembers the 4 people in a bed, that remembers the people dying in the hallways out in front of the lobby, that the families not finding enough coffins to bury their 7th family member in a month. That was what was going on in all the southern countries of Africa. Mozambique, Zimbabwe, South Africa, Namibia. That those countries were heavily burdened with it like that. But the Zambia discussion you referred to earlier, that was my first hit of coming out of a Ryan White domestic hit with Peter Piot and the person Joe O'Neill. We went on a fact-finding mission out of Lusaka to a local clinic that was run by Mormons. And they had a large hospital, not clinic, that was probably 100 beds, large for the South Africa, for Africa. And that was where we saw everybody with cryptococcal meningitis have a seizure, where 12 people in a large room all at the same time had a seizure. And I'd never seen anything like that before. And that was the moment I realized that, geez, I know how to diagnose and treat this disease, and not a person in this room is being appropriately treated for cryptococcal meningitis. So it's when I realized we did have a lot to give to our colleagues in the country that had been responding to this burden of disease without our help for years. So anyway, I would say that there's collegiality there still in that cohort of providers, but they're all going away now. Mm-hmm. Everybody in that age group younger doesn't have the memory of 5 people, and the need be exceeding the resources available. But mm-hmm. those who do still position differently with the same thing in front of them, the same clinical dilemma in front of them. That memory informs their reaction to what they're seeing now. And I see that all the time with current day folks. So that group's going to go away, and I think we're going to lose something when they do.
You just mentioned that this clinic was run by Mormons, and apologies for jumping around a little bit, but I wanted to ask you about the role that faith-based organizations played in PEPFAR. Can you talk about that role from your perspective in OGAC, how you worked with FBOs and what you consider their importance to be?
Yeah. Well, I would say Sandy Thurman really started a aggressive relationship with evangelical organizations that were out of her time as she ran the AIDS Foundation in Atlanta for many years in the early part of the epidemic. and then became the national AIDS coordinator for Clinton in the White House. And she, uh, I would say that I'm sorry, I forgot what part of that we were.
No, it's okay.
Oh,
The
oh,
role.
religious organizations, yeah. So Mark really saw that and Sandy as something that was untapped. I was introduced to the kind of religious organization force in this work in PEPFAR. I was not aware of them to the degree that I became, but quickly learned that the religious groups aren't in those cities that I was talking about in the capitals. They deliberately went rural because they didn't like oversight or involvement from the country ministries of health in their work once they started it. So they deliberately went out and started a hospital in a rural area that was not connected to the delivery system. And in almost every setting, they became the better facility, the more competent medical delivery site. Okay, for HIV, for deliveries, and in the community, they have that reputation as being the preferred place to go if you're sick. We took full advantage of that because, as I say, we wanted to go not just on the capital, but to move to scale in every country. And they were a big part of being able to do that as a resource that was already in the rural setting that we partnered with. So they played a big role. I would say an outsized role because of that.
This was a question I wanted to ask you at the beginning, but I think it fits as a concluding question. This was, at what point did you realize, I mean, your career really maps with the explosion of HIV/AIDS domestically and globally. Was there a point where you realized this is the thing I'm going to be working on for maybe my whole career?
Well, when I was at Southeast Health Center and everybody I had AIDS, they bubbled up underneath me. They were people that the clinic had been following for hypertension, diabetes, and coronary artery disease, uh, and developed HIV as a second, event as I came into the medical director role at the clinic. Saw my first cases there of HIV, and in the emergency room, they were the same group. The emergency room, the people who ended up in the emergency room at San Francisco General were coming from Southeast Health Center to the emergency room. So it was, I think that that was really something that I thought it was important, the role I played being there with an ID background to recognize this emerging new disease that no one had ever seen before in a population that would have been years before they were in front of knowledgeable providers for that disease. So that just wasn't going to happen in that setting. So I was grateful for that. Uh, I realized at that time, as I decided to go and with Paul and Connie Woofsy start the AIDS clinic at San Francisco General, Don Abrams, uh, that was a conscious decision that I knew I was doing that at that time. I'd done infectious diseases. I was really into the immune system and understanding immunology. Did not do research deliberately because I wanted to be the clinician, but to be the clinician in infectious diseases. So I was a pig in mud in the sense of a lot of infectious diseases. San Francisco General in the system is the heaviest with infectious diseases and always has been. Um, and um, and I, trained and gravitated there in my training. But so I was not unhappy with the knowledge and decision that HIV was probably going to be a big part of my practice, but did not see it as this was going to become a sole focus. Didn't think HIV was going to become that. Thought it was going to be another disease, just like the other 30 diseases that you know how to diagnose and treat if you're an infectious disease doctor or more. It's the approach, not the disease so much. But had done a lot of TB work and saw that as a failed attempt to capture and contain and was recognized a lot of the similarities with HIV and TB right from the beginning, wrote about it, but didn't really think I was going to dedicate to HIV until I really left Southeast Health Center and came back to the university to set up that AIDS clinic. And then really never left it. Ryan White, in one way or another, was everything I did was related to that. But you know, infectious disease doctors, because the bugs go into every organ, you don't forget how to take care of diabetes, hypertension, or coronary artery disease. You're seeing the whole body with that infection, and you take care of the sickest people in the hospital setting. You know, they are the people who are septic and are multi-organ failures and in ICUs. Those are ID doctors and intensivists that are looking at the patient every day too, with the cardiology consultant or pulmonary consultant. So I was in an element of disease that I liked to think about and got good at diagnosing and treating. So felt good about being able to share that as things moved.
Is there anything I haven't asked you? To be honest, there's so much we could talk about, but is there anything I haven't asked you today that you want to cover? We've had you here for a while, and I appreciate that.
Yeah, I think. Huh.
Any questions you have?
I think we've covered so much that it's pretty much what I would have brought up. If there are things that might come up that you think of, I'm totally okay with you coming back on it. I'm not doing this anywhere else. I did it years back a couple of times, but so it'll be curious to see how it's used. You know, if we live long enough to see kind of how it's used, but I hope it's used for the decision that a greater good agenda is still needed, and that if you learn all this science and medicine, you've got an obligation to give it back. And it's bullshit that you just go off into a private practice with a limited population, to me. That is a transgression of the knowledge you've been given. And the good you can do, you're taking a small piece of it to do. Do it. Knock yourself out. Do it well. I wouldn't criticize anyone who chooses to work in a small little community in a nursing home or something at all. That's all good medical work and counts just as much. But the numbers are what got my attention. You know, moving into the millions, ending a pediatric reflection of HIV in a whole population is gratifying in a way that I had not experienced, seeing patients one at a time.
Well, thank you so much for your time right in the middle of the day. I really, really appreciate it. And it's been a real honor to get to talk with you.
Yeah, thank you so much.
Okay, you guys, good luck.